Hi everyone, it's Kim Vopni and I am here for office hours in the Menopause Chicks community. So I have a whole list of questions here that have been asked already, and there's certainly I think in the chat here, if anybody wants to ask any questions as we're going along, then please do. But I am just going to jump in and start answering these questions. So one of them was, this person was recently diagnosed, or I actually don't know how recently, was diagnosed with overactive bladder and is now having side effects. So what are some of the other things that they can do? My first question is, with regards to overactive bladder, is if you've worked with a pelvic floor physio and has it been 100% determined that it is actually overactive bladder as opposed to potentially urgent incontinence or potentially patterning. So sometimes we can develop what many would call overactive bladder by putting ourselves in patterns of emptying more frequently than we really should. So normal voiding would be every 2.5 to 4 hours. And when potentially we have incontinence, or maybe because we have a job that doesn't allow us to void regularly, we will sometimes go to the bathroom just in case, and potentially that means that it's before the bladder is actually full. And then if that's done consistently, then the bladder starts to think that it's full here as opposed to here. So usually it's about 1.5 cups of liquid that comes out with a full bladder. The bladder can hold more than that, but that's generally kind of the accepted volume that comes out when you're voiding on a regular normal basis. So if we're voiding more regularly as a pee just in case type scenario, then what can happen is the bladder becomes strained and it just starts to signal more often. And then every time that we're responding to those signals, then the bladder's like, okay, I got it. And it will continue to do so. And that can happen. And then people say, if they go to their doctor, they'll often say they go to the bathroom, and some of them might have a bladder diary that you complete, which I do recommend at least for 3 days. And that can help you point out certain foods that might be irritating your bladder. Maybe you drink volumes at a short period of time and then you don't for a while, and then you have another large volume, or it just starts to point out patterns and things that could be contributing to some of the sensations that you have. So I would want to get that done first, and also see if you could train your bladder the other way. So just like it can be trained to signal more often, we can also train it to not signal as often. So bladder training is typically done best at home. And when you are training your bladder, it's ideal that you can use your bladder diary while you're doing it. But when you get a signal to empty, so if your bladder is saying that I want to empty now, note the time, and you can go void for your first time. And then after that, if it signals, say, in another 30 minutes or 45 minutes, then you're going to talk to your bladder. And I always joke that you can say this in your head, or you could actually talk out loud to your bladder if you like. But you're going to walk into the bathroom and you're going to stand by the toilet, and you're going to talk to your bladder and say, I know you're not full. I haven't had an inordinate amount of liquid, like I haven't had a liter of water or even 2 cups of water in the last half an hour since we last went. I know you're not full. I'm not going to respond to your requests. And you're doing this while standing at the toilet. And you can also do it at the same time as you're doing calf raises. So you're sort of lifting your heels off the floor and coming up on your toes. And that can interfere with the signal that goes up to your bladder. And it's a bit of a distraction as well. And then eventually that bladder, the sensation, the signal to void will start to dampen or will stop. And then you move on and you walk away from the toilet and you don't empty. And then you start to increase the window so that you're in that 2.5 to 4 hour window zone. So I would want to rule that out, or at least investigate that and try that first before you go down the medication route, especially if you're having side effects. So I would recommend bladder diary, bladder retraining, and working with a pelvic floor physio, and seeing if that would help you. So Shirley Weir agrees with me that you should talk to your bladder. Okay, so next question. is with regards to hysterectomies and what needs to be considered. So hysterectomies are one of the most common procedures performed in North America. And oftentimes, early stage prolapse, so organ prolapse is something I'm going to talk about in a minute as well. So if somebody is dealing with organ prolapse, and if they are no longer planning on bearing children, then oftentimes a hysterectomy could be presented as an option. And it can be life-changing for some. Some people have it for fibroids. Some people have a hysterectomy for heavy bleeding. Sometimes it's for prolapse. There's lots of different reasons why a hysterectomy may be chosen or performed or needed. And when a hysterectomy, so if you can imagine that this is the vagina, and at the top of the vagina is the cervix and the uterus, and this would be the anterior wall, and this would be the posterior wall of the vagina. So when the uterus is taken out, and sometimes it's taken out with the cervix and the ovaries, or sometimes they're left behind, but regardless, when the uterus is taken out, there is now a space there. And what can happen if it's not communicated to women, again, surgery can remove symptoms and can be life-changing, but from a lifestyle management perspective going forward after surgery, it's important for women to know what has changed in the landscape in the pelvis. And when there is that space there, and where things have been, again, kind of reattached in different places, it may contribute to the development of other types of prolapse. And movement practices and physiotherapy really plays a huge role in terms of managing life after hysterectomy. So with regards to what needs to be considered, there's also different types of hysterectomy. So you would want to know which type that you're having. But bottom line, regardless of the type that you're having or the reason why you're having it, I do recommend that women work with pelvic floor physio. You hear me say that ad nauseum, beforehand, before surgery, as well as after surgery, and then ongoing. I recommend pelvic floor physio to every woman, even if you have no symptoms, even if you have never had surgery, but especially if you have had surgery. I do believe that it is really, really beneficial to have from a prehab and a rehab perspective. I also am a big supporter of a technique called the hypopressive method, which I do love for prolapse and incontinence, and also if somebody has had a hysterectomy, to prevent other types of prolapse, again, because we have that space. So pelvic floor physio, paying attention to your posture and learning how to manage your pressures with movement and fitness, and investigating the hypopressive method. Okay, I'm just going to keep going down the list here. This person has itching and burning and was prescribed meds for a UTI. And so basically what else can they do? So in menopause, with the decline of estrogen, it's very common to have discomfort such as itching and burning and dryness, atrophy. Dryness and atrophy can sometimes mean the same thing. And because there's such common general symptoms, they now have a new descriptor called genitourinary syndrome of menopause, GSM. And those symptoms can be easily treated in some. So vaginal estrogen therapy is something that can be beneficial for some. I do recommend having hormone testing done just to sort of see where your levels are at. But one thing I would try first would be hyaluronic acid from a vaginal moisturizer perspective, and it can be used daily. I know Shirley has been posting the one that she now has from Pure Pharmacy that is really, truly very pure. There's no other additives in there, which I really love. It's very clean. So I would want to investigate that. And the other thing to consider is that UTIs often develop around the time of menopause because of the vaginal dryness and atrophy and irritation that's happening. So the two, it's kind of like a chicken and the egg scenario as to which one comes first. So stay on top of keeping the tissue hydrated. And the good thing about hyaluronic acid is it not only keeps it hydrated and helps soothe, but it also helps heal any tissue that has had any irritation. So I definitely highly recommend that. But consider also that it is different than lubricant. So lubricant would be used in addition for sexual activity. And there's lots of different lubricants that have that are very clean as well. I really like Liquid Organics. Yes, lubricants are also a really good one. But choosing one that is, there's no other irritants that could be in there that are really quite clean, so that they're also not going to contribute to further challenges. And glycerin can sometimes be an ingredient that can contribute to some irritation. So I would try vaginal moisturizers and see if that's helping, and also potentially manage it with a different lubrication. This one is, the question was, or it was more of a comment, but they feel like they have a tampon. It's almost like a tampon was potentially lodged or stuck in their vagina. So that's definitely an indicator or a common symptom for pelvic organ prolapse. So again, if you consider that this is the vagina, and the uterus and cervix are on top, this is the anterior wall of the vagina, and the bladder would be here, and then this is the posterior wall of the vagina, so we would have a rectum in here. And prolapse could be one or all of the organs. So in a uterine prolapse, the uterus would start to descend into the vagina. In extreme cases, it could actually bulge right out. In a bladder prolapse can be called a cystocele, a bladder prolapse, or sometimes an anterior wall prolapse, so anterior wall of the vagina. So in a bladder prolapse, the bladder starts to bulge into the vaginal wall, and again, in extreme cases, the bulge can come right down to the entrance or potentially outside of. And on the back wall, you can have the rectum that bulges into the vagina, and that would be considered a rectocele or posterior wall prolapse. If you hear the term rectal prolapse, that's different, and that's where like part of the rectum actually comes out of the anus. So these we're talking about bulges and protrusions out of the vagina. A rectal prolapse is when parts of the rectum would bulge out of the anus. So with the rectum here, if it bulges into the vagina, it's called a rectocele. I have a stage 2 rectocele. Statistics say that over 50% of women have some degree of prolapse. In the first 6 weeks, 6 weeks postpartum, it's like 80% of women have at least some degree, and about 50% are around a stage 2. So it's very, very common. But early stage prolapse can be asymptomatic. So for me, I manage mine very well. I hardly have any symptoms at all. But there are some people who could have a stage 1 or stage 2 that could have a lot of symptoms. So it's really dependent on the person, and the sense of the symptoms or the severity of the symptoms doesn't necessarily indicate the stage of prolapse, or even if it is prolapse. But people feeling like they have something in there, people feeling like maybe it's like a tampon that's not in correctly. Sometimes people can put a tampon in and maybe it doesn't stay in. Sometimes people during intercourse maybe feels like the penis or fingers or toy hits something. It could be a sense of heaviness in the pelvis, maybe a sense of pressure, maybe feeling like something's going to fall out. So those are all kind of common symptoms. But some of the other ones could be low back pain, could be hip pain, sometimes even knee pain. So there's lots of different things that could potentially point to a prolapse. And from a management perspective, generally speaking, bladder prolapse and a uterine prolapse are, especially early stage, like stage 1 and 2, are usually more easily improved. Sometimes they could potentially even be reversed. And how to do that would be pelvic floor muscle training, so pelvic floor fitness or kegels done with movement, as well as the hypopressive method. So hypopressive means low pressure. And the hypopressive method, when you watch it, it looks like the abdomen is kind of drawing in and up. So it almost creates a bit of a suction that sort of lifts the viscera up. And when done over time, it works on the involuntary muscles within the core, and it can help, while you're doing one, there is a bit of a suction, and done over time, that suction stays up. So it can help move the organs back up to where they were and help them stay there. I think a balance between actual voluntary training with kegels as well as hypopressives that's kind of now become my gold standard in conjunction with pelvic floor physio. So I would, if you can, go see a pelvic floor physio, and you will get an understanding of if there is a prolapse there, which organ it is, and what stage it's at. The challenge with seeing a doctor when you have symptoms like this is they may do an exam, and they may put a speculum in, and when a speculum goes in, it opens up and could push bulges out of the way. So make sure that they are doing a non-speculum exam, and they would be using fingers. They will often ask you to cough or to bear down. A really good assessment would include you being assessed in standing. So usually when you're lying down on a bed, pardon me, the gravity is taken out of the situation. And then as soon as you stand upright, the landscape of the pelvis and the position of organs could potentially change. So it's important to have a standing assessment. And go, like, if you, sometimes people say, well, I wake up in the morning and I'm fine, but by 3 o'clock or 4 o'clock or by dinner time, I feel a lot of heaviness or I feel a lot of pressure. So they become more symptomatic as the day goes on, which again, if you've been upright, or especially if you've been lifting or moving a lot through the day, that could happen. So you may want to see the therapist or the physician at a time of day where the symptoms could be more pronounced, because it could look very different in the morning compared to the afternoon. So I would go and investigate that. I feel like I have to go to the bathroom all the time. So this was kind of back to the first point that I was making with regards to how we can sometimes get into the habits of training our bladder to signal us more often. And this can go back, for those of you that have had children, when we have young babies and they are up multiple times in the night, we can sometimes just, unbeknownst to us, we just are up and we're like, oh, I might as well go to the bathroom. And then again, we start to train the body in certain ways. And then when we have young children, oftentimes we will ask them to go to the bathroom just in case, because we're going out or because we're going to be in the car for a while or what have you. And so we're always kind of in a state of going just in case, and then we could imprint that on our kids as well. But then those habits never really go away. And then when the changes in hormone is happening as well, it can sometimes exacerbate that situation. So go back to the first answer, which was regards to pelvic floor physio, bladder retraining, and using a bladder diary. And hopefully that would help you learn a little bit more about what might be contributing to it. So this was a question posted in the group with pain, somebody having pain with intercourse. They're using Vagifem, and they were wondering if lasers would work. So in the last probably like 5 or 8 years or so is probably when it's become the most common. There has been a huge rise in technology available for vaginal rejuvenation. And I've looked into many of the different types of lasers to try to learn more. Some of them are lasers, some of them are light therapy. The most common ones that are out there that you would see are one called Viviv, which uses, I have to write this one down because it's cryogen cooled monopolar radio frequency. So that's quite a mouthful there. Of all of them, I will say this is my favorite because all of the research and talking to doctors that I was doing, it was the one that was able to penetrate the deepest. So it's about penetrating the layers of tissue to stimulate collagen and lubrication and moisture is essentially what they're all trying to do. And this one had the deepest ability had the best ability to penetrate the deepest. And it was no downtime. It wasn't ablative to the tissue where some of the other ones are. So I felt like if you were going to try one, now let me just say that Viviv is not specifically for pain with sex. So if the pain was to do with dryness and irritation, then it could potentially help with that. So it's about determining first what is contributing to the pain. And I think if I recall on this question, there was, it was more so about some of the potential irritants from the products that were being used, I believe. It was, and if you're on this call, you could correct me if I'm wrong on that. But so I'm kind of answering this as a general laser question in conjunction with the pain with sex. So Viviv isn't sold as something that will help with pain with sex, but if part of the contributing factor is dryness and irritation, this can help with lubrication and it can increase sexual satisfaction or sensation. There's also the CO2 laser. So the Mona Lisa Touch is another one, which if you look into that one can be used and has been shown for some people to help with painful sex. This one is ablative, meaning it when it's inserted, it's almost like it's creating tiny little holes in the vaginal tissue that then stimulates the production of collagen and rebuilding of the tissue. So that's what's happening with that one. So they don't really mention that it's downtime per se, but it could be potentially a little bit more, there may be a bit more discomfort. And there are some people who have actually had challenges afterwards, meaning they didn't necessarily have major issues going forward, but now they are dealing with other painful syndromes. So if I was going to pick one, I don't think I would go right for the CO2, the ablative type ones. There's another one called the Erbium YAG, which is a little bit less than the CO2 in terms of disruption, maybe. It doesn't penetrate quite as deep, but again, if I was going to choose some sort of a laser, then a Viviv is probably the one that I would lean most towards. Not necessarily for painful sex, though, I will say that. On this, so somebody else was asking about the V-sculpt, which I'm going to lump into this answer because it's sort of similar. So the V-sculpt is a home use. All the other three that I mentioned, the Photona, which is the Erbium YAG, the Mona Lisa, which is the CO2, and the Viviv, which is the cryo-cooled monopolar radio frequency, those are all professional, meaning you need to have somebody deliver that for you, either a doctor or a technician in a clinic. The V-sculpt is a home use device, and it's kind of like a giant dildo in a way. I call it like a lightsaber too, because there's lights on it. So it uses sonic vibration, it uses heat, and it uses LED, so infrared light. And it's the combination of those three that they have put into one that has been helping. So again, not necessarily designed for painful sex, but from a device that could potentially help with dryness and irritation that could be a contributor to painful sex. This may be an option as well. I have tried the V-sculpt. I used to sell them when I had my online store, and I do really like it. I like the addition of the vibration for two reasons. One, because I'm a big proponent of pelvic floor exercise, we know that vibration training, so if you've ever seen those vibration platforms that are in a lot of gyms, vibration training can involve more muscle fibers. And when you put the vibration of the V-sculpt on and you do your kegels while you're using the device, you're getting pelvic floor muscle training with some vibration, which I think is beneficial. The vibration can also be helpful because you can have an added benefit of masturbation after as well. The heat is a nice, gentle, warm heat. It feels quite nice, and you don't have to do kegels while you're doing it. You could just sit there and enjoy the heat aspect of it. So it's easy to use. It's cheaper than the ones in the clinic, And I think there are some benefits. They have some decent studies that are happening that you could look at as well. So I do like the V-Sculpt, again, not just like as a blanket statement, everybody should have one. If you're going to invest in something, invest in a pelvic floor physio assessment first. If you have that, if you have access to that, it really truly is always my go-to, hands down, number one thing that I think every woman should try. And they can then help you understand what your pelvic floor needs and if any of those therapies would be beneficial or not, or if they're even worth trying or not. So that would be for that. Excuse me. Another person had asked about a stage 2 bladder prolapse and would it improve with exercise? They're 53, they had twins, and is it too late? So no, it's never too late. And stage 2 would I consider as an early stage prolapse, and especially bladder and uterine. Again, they are the most likely to be able to improve. So same as I've said, ideally pelvic floor physio, pelvic floor muscle training, as well as hypopressives. And hypopressives are something that I coach women on, so I teach women online. I have it as part of my online program. You can find trainers. Also, if you Google either hypopressives or low pressure fitness. So in Canada, it's Hypopressives Canada. In the United States, it's lowpressurefitness.com. In Europe, it's also more so called low pressure fitness. But if you Google the term hypopressives, generally you can find people around the world who are trained if you want to work with somebody in person. But no, absolutely, it's never too late to make a change. And I think that that's something that a lot of people believe, that if they haven't done anything and now they're in their 50s or now they're post-menopause or what have you, that nothing will ever change. And that's absolutely not true. There's so many things that we can be doing from a tissue management perspective to nutrition and movement. And it's absolutely not too late. So carry on. Okay. I see interstitial cystitis, many flare-ups on meds, but have many issues. Okay, so not too sure what your question would be on that, but if you wanted to clarify and ask from a management perspective, I know that it can be a bit of a challenge to manage interstitial cystitis. Nutrition is something that is a big piece. I'm actually working on a nutrition certification right now, so I'm not, as it stands, able to provide nutrition advice. However, I can advise you to potentially work with a naturopath or a holistic nutritionist and look at inflammation in the body. So looking at reducing the amount of inflammation that may be in the foods that you're eating, that could be something that you might want to check out. Another one here is the bladder fills up and you feel a lot of pressure and it's very uncomfortable. So it could potentially be a prolapse, but it could also be restricted muscles. Just because we feel pressure doesn't always mean that there's a prolapse. It could mean that so with muscles, if muscles become too tight or constricted, they then aren't moving through their optimal range of motion. And with regards to the pelvic floor, if there's maybe a muscle that potentially is pulling more on one side than another, that could contribute to different sensations. So you could check out that. I'm going to get rid of this form because I think I've answered everything on there. But also measure how much. I always say go to the dollar store and get a set of measuring cups that will never make it into your kitchen and pee in them and just see how much volume comes out. And as I said, usually normal voiding is around a cup and a half of liquid, kind of around at least a steady stream for 10 seconds. And also know that when you sit down to pee, there should be no pushing happening. You should sit down and allow the pee. So what we want is the bladder to contract and the pelvic floor to relax. And oftentimes people sit down and maybe they feel like they need to pee quickly or they want to get all the last little bits out because they never feel like they empty completely, so they will push. And when you push, it engages the muscles in the abdominal wall and in the pelvic floor, and then the bladder can't empty as effectively. So when you sit down, really make sure that you relax the pelvic floor. But with regards to this question, I'd be curious to know how much urine or liquid is coming out, and if you know if you do have prolapse or not, or if you've worked with a physio, I would definitely check that out. Lots of people saying hi. Hello, everybody. There's the link to the moisturizer, and here's another question. I posted a question on kegels, but don't see it here. Can you please explain the best techniques as well as how often I should do them? Is there a progression for these exercises, and will they help with painful sex? So kegels are if anybody's ever heard of anything to do with pelvic floor exercise or pelvic floor fitness, it's kegels. And kegels are often prescribed, but they're very rarely taught. And a true kegel is, people think a kegel is sitting and squeezing, just squeezing your vagina. But really there should be a kind of a drawing together of the edges, and then a lifting up into the body, and then a letting go. I have a video on my YouTube channel and on my website that gives you a visual with my vulva puppet. But essentially it's like it's a drawing together, and then a lift, and then a letting go. And what's happened over the years is the lift hasn't always been considered, nor has the letting go. It's just been a squeeze. And a lot of people actually in turn will use their inner thighs or their glutes to do that squeeze. Sometimes they even hold their breath and bear down, which could contribute to other challenges, but also makes the exercise itself not effective. So learning how to do them correctly is really important. You can assess yourself for it. If you take 1 or 2 fingers and you insert them into your vagina, and when you do your Kegel, can you feel like there is a bit of a hug on your fingers? And then, like, you're not going to be pulling your hand right up in there, but there should feel like you can sense that there's maybe a little bit of a drawing up. And then when you take your breath in, can you let that go? You can use your partner, so your partner's fingers. You could use your partner's penis if you have a male partner. There's one, so a lot of people ask me also with regards to Kegel, yoni eggs, Kegel balls, that type of thing. There's one device that can distinguish between people that bear down versus people that actually do the Kegel properly, which is called the ELVIE, ELVIE. And it's the biofeedback, so it can, you look on your app when you're using the device. So that can be helpful for some with regards to learning how and training the pelvic floor. Still, in my opinion, gold standard is pelvic floor physio. And before you invest in a device, I would highly recommend that you see a physio first. If you don't have access to a physio, then a device like that could potentially help. But I would try with your fingers or your partner if you have one first and see if that helps, and then potentially a device could help. Now, back to kind of this question, the other piece of Kegels that has been maybe misunderstood is people say, oh, I should do them. So I do them at every red light, or I do them while I'm brushing my teeth, or I do them before I get out of bed in the morning, which is better than nothing. Oftentimes the positions that we're in, especially sitting in a car, aren't necessarily conducive to allowing the muscle to work through its full range of motion. But also it doesn't necessarily translate into our activities of daily living and our exercise. So if I was to sit here and do 3 sets of, like, do 100 Kegels, which is often what's prescribed, and then I go about my day, I leak when I pick up my groceries, or when I lift my children, or I leak when I go for a run. So at some point we need to be able to be training our pelvic floor in movement. It doesn't make sense to train sitting down and then go about my day and expect my pelvic floor to know how to work. It did when we were young. We didn't have to be told how to do Kegels when we were young. Our core is anticipatory. It should be anticipatory, and it should work automatically, but lots of things can interfere with that synergistic system. Life, posture, pregnancies, childbirth, surgeries, car accidents, falls on the tailbone, all sorts of things can hinder the ability of the pelvic floor to work in an automatic way, and that's when the symptoms start to show up. So we need to be able to connect in with the pelvic floor, learn how to activate it appropriately, and then bring that activation into movements like squats and lunges and push-ups and all sorts of things. So if you were to read literature with regards to what is a gold standard for Kegels, it's 3 sets of 10-second holds done 3 times a day. So that's kind of, and so there are some physios who would prescribe it as that. I take the stance of, I'm okay with doing maybe a set sitting in a chair or a set lying down in bed, maybe when you're brushing your teeth if you want to. But ideally, if we can do it when we're exercising or moving, then we most likely will actually do a little bit more than that 100, depending on how long our weight training session is. But we start to incorporate our core, because the pelvic floor is the base of the foundation of our core. We start to involve our core into more activity. And a lot of women, once they are truly activating and using their core properly, will lift heavier, can run faster, can run longer if that's their goal. So it really can help improve performance. So the best technique is really watch my core breath video on my YouTube channel. And I use the term core breath to basically describe the functional Kegel, where I want people to understand the relationship of the breath with the pelvic floor. And I go through a bunch of different cues in there that help women activate their pelvic floor as well, because just saying do a Kegel is not always helpful. That doesn't always mean a lot to every single person. So if we can start to use visualizations, pick up blueberries with your vagina and your anus, sip a milkshake through a straw with your vagina, imagine a tampon is falling and lift it back up, pull your partner's fingers or penis deeper into you, imagine a jellyfish swimming, and as it propels up to the surface of the ocean, that's your exhale, that's your contraction stage, and then inhale and softly float. So there's lots of different cues. There's no best one. It's which one is best for you and which one elicits the response that we're looking for. So the best technique is, I would start with that first if you can. See a physio if you can. And in terms of how often you do them, I usually say if you can do some Kegels every day or do some pelvic floor fitness every day, great. And when I say every day, I know that usually translates into 3 to 4 times a week. So that would be ideal. And it is something that I do promote as a lifestyle. It's not a quick fix. And once you notice a reduction or elimination of symptoms, then you stop doing them. It's something that really needs to be developed into a lifestyle, into habits. So with regards to will they help with painful sex, again, it really it depends on what's contributing to the pain and what's the cause of the pain. So sometimes when people focus too much on the activation, so the contraction and the lift of the pelvic floor, that especially if they already have a pelvic floor that's maybe holding on to more tension than it would be considered optimal, then that could contribute to even maybe more painful sensations, or maybe that's the reason why pain is happening with sex in the first place. So my programs and my belief always centers around a balance between up training, which is the contract and lift, and down training, which is the letting go. And some people may need to focus more on one aspect more so than another. So if painful sex is happening potentially as a result of constricted tight muscles, then doing more Kegels with the focus here wouldn't necessarily be of benefit. You would want to focus more on the down training. So pelvic floor release exercises, I have a couple on my YouTube channel as well. Hamstring lengthening, glute relaxation, also some glute activation may be helpful. But again, I would definitely check that out. Painful. So the term for painful sex is dyspareunia, but there are also other types of pains in the vulva, in the vestibule, that can also kind of be lumped into painful sex. So you'd want to understand, is it pain with penetration? Is it pain because of fear of penetration? Is it pain on the vulva from any touch? There's lots of different contributing factors. So if you have access to a physio, I would definitely check that out, because it's very, very, very treatable. And it's not something that you need to suffer with or live with. It's important to understand what the cause may be, and then what balance of pelvic floor fitness would be the best approach. Hi, Rhonda. Thank goodness I wore my sweater today. Yep, that's right, Shirley. I try to wear some sort of, when I'm talking about pelvic floor, I try to have something that I can show my vagina sleeve. Hi, Marianne. Thank you for your comment. You're welcome. Do you need a doctor referral for a pelvic floor physio? Good question. No, in Canada you don't. Let me just back up. You don't need a referral to go and see a pelvic floor physio in Canada unless your benefits plan, if you have extended health coverage, requires it. So no, so you don't. So in Canada, you can call up any pelvic floor physio and make an appointment. I will tell you that most pelvic floor physios have a fairly significant wait list. I generally at least a couple of weeks. Some can be upwards of 6 weeks, unfortunately, because we need more. But get on the wait list or make your appointment and go. It's an incredible investment into your own health. So I'm not sure where you live, but no, if you're in Canada, you do not need a referral. And in the States, as far as I know, you also don't. A lot of them are private pay. So if they are private pay, you would not, again, unless your health plan required it. What do you feel about pelvic physio for painful sex, and what exactly do they do in postmenopausal? So I just talked a little bit on the last answer about how pelvic physio can help. With regards to how they do it, I don't think I think my vulva puppet is in my car. I'm sorry. But so pretend this is the vulva right here. Let's do that. There's your vulva. And a pelvic floor physio will look externally. So first of all, pelvic floor physios are regular physiotherapists who have additional training in the pelvic floor, and they are licensed to go beyond the introitus, which is the entrance to the vagina. And they use gloved fingers. They will often look externally at the whole body first. It's a whole body approach. It's not, the whole session is not just an internal assessment. So they look at movement mechanics, they look at breath strategies, and when they do an internal, you would be draped in a gown, and they would use a gloved finger to assess the external genitalia. So they would be looking for any abnormalities, potentially with skin color, maybe if there's any scarring from previous surgeries or episiotomies or tearing from childbirth, if there's any scarring from potentially a cesarean section. Then they would take one and maybe two fingers and they would insert it into the vagina. And what they are feeling for is, first of all, can they insert a finger? And when they do, what do they feel in terms of the two sides? Is there balance in tone? Is one side, is there more give on one side than the other, which maybe is a bit more rigid? Ideally, we want to have a little bit of give, not too much, not too little. There's sort of a Goldilocks spot there, but we want that to be balanced. They will then ask you to do a pelvic floor contraction. And this is not always the same order that this happens in. These are generally the points that they would cover. They will ask you to perform a kegel. So they're going to feel for, can you hug their finger? Is there a bit of a drawing up? And then can you let that go? They'll also feel and look for the position of the organs. So the bladder, the uterus, the rectum, if there is still a uterus there, and see what it looks like lying down. And then again, a good therapist will also assess you in standing and see if, and a really, really good therapist will also assess you with movement. So if you're in a squat or potentially doing a lunge, they can feel for the normal response to the pelvic floor and if there is any descent of the organs when you are going through that movement. So with regards to painful sex, again, it can be a question of what is the pain. So is it pain with penetration, or is it pain with fear of penetration, or is there general pain around the vestibule, so the opening, or pain in the whole vulva? Sometimes with pain with penetration, it can be working with dilators. So if you can imagine that this would be, you know, potentially the smallest dilator, and then they progressively get larger and larger and larger, and it's about working to increase the confidence and comfort and belief that something can be inserted without pain. Pain could also be being brought on by tight muscles, so working to down regulate that system. It could also be from scar tissue. So if here's the vulva, and the vagina is inside, and down here would be the anus, and the perineum in between is somewhere that it's very common for women to have scar tissue from tearing or from an episiotomy. And scar tissue we need adhesion. So when there's an injury or a cut to our tissue, the response of the body is to create adhesions. That's part of the normal healing process. But those adhesions can sometimes stick or get stuck to potentially an organ, or just stuck in a really tight, constricted place where it doesn't allow for the flow of nutrients and what have you. So being able to access that tissue, either the therapist does it manually, or if you were doing self-massage, there are things called Thera wands or pelvic wands, which are silicone. Usually they're shaped sort of like an S, that allows you to insert and then push on those trigger points or into the scar tissue and be able to release it. So there can be scar tissue externally as well as internally. I know that I had 2 vaginal births and I had no external tearing. And it wasn't until I saw my physio that I realized I had internal scar tissue from tearing that I didn't even know that I had. So it could be in any of those places. So those would be probably the most common ones that would be considered with what the therapist would do. But they take a whole body approach. An assessment, an initial assessment is usually around an hour. Follow-up sessions could be anywhere from 30 minutes to an hour. Very different from when you go see a doctor, which your sessions are typically, especially the family doctors, usually around 5 to 10 minutes. And I believe it's a much more woman-centered approach to understanding your body, and also getting the treatment that your body may need. So I can't say enough about it. Hi, Sue. Okay, so I think I'm out of my questions here, and we still have about 10 minutes. If there's anybody who has any last minute questions, please feel free to jump on. Thanks, Shirley, for jumping in there and reiterating and sort of summarizing some of the main points. That's been awesome. So there's some free resources on my YouTube channel, as well as my website, vaginacoach.com. If you have any other questions, you can certainly reach out to me, kim@vaginacoach.com. Either you can also message me through the community. But other than that, I think I'm going to probably jump in here once a month and have office hours. So you can either email me or message Shirley with questions, or do as we did today, where we had lots of great participation. So thank you, everybody. Oh, wait, there's one more. Oh no, that's just a thank you. You're very welcome. Thank you very much. I hope you enjoyed it. And other than that, we are done. So enjoy your day, and go make a pelvic floor physiotherapy appointment. Okay, bye.